Hi guys, we're going to look at chapter 46. This is nursing care of the child with an alteration in cellular regulation, hematologic, or neoplastic disorders. So we're going to hit on several different disorders here, and I just want you to be aware of all of this information for your exam. So let's get started here. So we know that there are functions of the hematologic system. We have different blood cells. The erythrocytes, or our red blood cells, are responsible for transporting nutrients and oxygen to the body and waste away. If we have low red blood cell levels or issues making these cells, what are we most concerned about? And you should think about oxygenation. Thrombocytes are platelets. These are our clotting factors, so they are responsible for clotting. Too much can cause overclotting, too little can cause underclotting. And then the last one is our leukocytes, our white blood cells, and remember those are the ones that are going to help us fight infection. When we think about our red blood cells, remembering that is composed of hemoglobin, and erythropoiesis is the production of those red blood cells. Hemolysis is the destruction. Pediatric patients with hypoxia will stimulate the production of RBCs to help decrease the low oxygenation that is being experienced. One of the major hematologic issues that children face is anemia. Anemia is the most common hematologic disorder of childhood. The decrease of RBCs and or hemoglobin, which again are those oxygen carrying blood cells, decreases. That decrease in oxygen carrying capacity decreases the oxygen to those tissues. The decrease in the RBCs and hemoglobin can be due to a decrease in production, cell loss, or cell destruction. Nutritional deficiencies that can cause anemia include iron deficiency, folic acid deficiency, and pernicious anemia. And we are going to focus on that iron deficiency. So when we look at iron deficiency anemia, this occurs when the body does not have enough iron to produce hemoglobin, usually from an inadequate supply of dietary iron. It's generally preventable. The therapeutic measurement, or what are we going to do with these kiddos, is we're going to give them those iron supplements. That ferrous sulfate is our preferred form because it absorbs the best. In severe cases, we may have to think about blood transfusion. As far as nursing assessment, we're going to start with history. We're going to talk about our risk factors. We're going to evaluate the diet history, and then we're going to observe. We're going to probably observe some fatigue and lethargy, because remember, we don't have those oxygen carrying cells going through our body, and it's going to cause some of that fatigue. We also will inspect. We're going to inspect the skin, the conjunctiva, the oral mucosa, palms, and soles for pallor. If we see any spooning of the nails, that concave shape of the nails, that can occur with that iron deficiency anemia because of the increased hypoxia that these patients result in. We know that tachycardia is a sign of prolonged anemia, as well as splenomegaly. So as we're auscultating and palpating, we want to make sure we're looking for those symptoms. So what's the recommended dose of elemental iron for these iron deficiency anemia patients? If we're thinking prophylactic, you can see that there, 1 to 2 milligrams per kilo per day with a max of 15. Mild to moderate, we're going to go up to 3 mg per kg per day. And then severe is going to get that 4 to 6 milligrams per kilo per day. And we're going to divide that in 3 divided doses. So the next one that we want to talk about is toxin exposure. And this can include lead poisoning. So let's look at lead poisoning a little bit. The peak of incident is between 1 and 5 years of age. When lead is seen in those red blood cells, it creates smaller red blood cells, which leads to the anemia. Sources can include paint in those homes that were built before 1978. So most homes have been repainted since then, but we will still find a few older homes that have that iron from the dust in the windowsills, the walls, and the plaster. Soil where cars have been used for leaded gas have been parked is a high place for lead. Glazed pottery, lead pipes, sometimes the clothing of parents who might work at certain manufacturing jobs, when they come home, they need to take all of those clothes off and get them away from those kids because of that just lead exposure. Toys is another one that we can think about, and you'll start, as the toys have been better made, that lead is no longer a problem. So some of the complications of lead poisoning can include behavioral and learning problems with those lower levels, encephalopathy, seizures, and brain damage with those higher levels. I think the worst case that I'd ever seen was a set of siblings, and they were eating the dirt outside of their home. So we know that a normal lead level is less than 5. These siblings had lead levels of 52 and 63, and it wasn't the first incident of having these high levels. So how do we treat these high lead levels? We do chelation therapy, and we usually start that intravenously. We can give it oral, but with those high levels, especially with those siblings, we need to get it into their system quickly. That chelating agent removes the lead in the soft tissue in the bones, and it goes out through the renal system. So how do we prevent lead poisoning? We need to make sure we're doing lots of education at early screenings, and that's really the key to prevention. We need to help parents understand where that lead can be found. When we think just about foods rich in iron, especially for our anemics that have a dietary issue, these would be a lot of the high iron rich foods: red meats, tuna, salmon, eggs, tofu, grains, beans, leafy vegetables, cereals. So again, another educational point that we can do for our families. Aplastic anemia include acquired as an adverse reaction to medication. Rare congenital bone marrow is that Fanconi anemia. So I'm just going to quickly go over aplastic anemia. When we think about the history as we look at the assessment, we need to look at exposures to myelosuppressive medications or maybe radiation therapy. We talked back in week 1 that we don't like to put a lot of our patients through x-ray because of that radiation, especially at those younger ages. And this could be a main reason why. We're going to get a detailed family, environmental, and infectious disease history. Epistaxis or bloody noses, gingival oozing, or increased bleeding with menstruation, headache, fatigue are going to be some of those big assessment findings that we might hear based on history. Some of the physical examination findings that we might see are ecchymosis or bruising, petechiae or purpura, oral ulcerations, tachycardia, and tachypnea. And then the last type of anemia that we're going to talk about is hemolytic anemia, and that is going to be our sickle cell patients or our thalassemia patients. So what is sickle cell anemia? It is a genetic disorder that causes red blood cells to sickle or change shape. Sickled cells are stiff and sharp instead of soft and round. These cells can cause problems all over the body. Sickled cells block flow in the blood vessel, which deprive tissues of that oxygen. This deprivation of oxygen causes what? It causes tissue damage and pain. So what can we do to help these patients? We need to oxygenate them. We need to prevent crisis because of infections. We need to control their pain, and we need to really push lots and lots of fluids. So this is the most common anemia. It's an autosomal recessive disorder. It does occur primarily in African Americans. About 1 in 12 African Americans are carriers, so they have that sickle cell trait. And about 375 infants are born in the U.S. with sickle cell. It can also occur in our Mediterranean, Middle Eastern, and Indian descent populations. So instead of hemoglobin AA, which is that healthy older infant hemoglobin, sickle patients have hemoglobin SS. So the lifespan is much shorter. So many children will have to undergo a splenectomy, which will lead to severe compromised immunity. There's decreased oxygenation, stress or infection. Those cells can become very elongated and sickle in shape. So if we can give oxygen to help facilitate the cells moving through the bloodstream, it can help prevent further sickling. Clumping can occur, which causes obstruction and pain. We'll also see patients with tachycardia, tachypnea, which again is just going to lead to more sickling. So again, what are we going to do for these patients? We're going to definitely do some oxygenation, prevent that sickling crisis, prophylactic antibiotics, and then appropriate immunization coverage. Those sickling crises can lead to pain, typically abdomen, long bone, and joint, but are the ones that are going to have the most pain, but really it can happen anywhere within the body. So we want to make sure we're performing a thorough assessment. Sickling, hypoxia, and tissue ischemia affect most areas of the body. We can measure their temperature to evaluate for infection, remembering that infection can precipitate sickling. And we need to determine their mental status baseline, so doing a really good neurological assessment. And that's going to help us recognize those stroke symptoms a lot quicker. Dactylitis is the swelling of the hand, and sometimes you'll hear it saying, you'll hear people call them sausage fingers. So another just very common symptom of sickle cell. What are our labs and diagnostics to assess? Hemoglobin electrophoresis is really the only accurate test to help us test for that hemoglobin SS. It's going to help us diagnose sickle cell. There are other common labs after sickle cell diagnosis. It's that retic count, which will be greatly elevated. The peripheral blood smear will have the presence of those sickle-shaped cells and target cells. Our platelet count will be increased. Our ESR will be elevated, and we will have some abnormal liver function tests with an elevated bilirubin, which just means that lysing or breaking down that bilirubin is just really escaping from the blood supply. So nursing management, hydration, oxygenation, and pain relief. If they do have a pain crisis, we want to make sure we are assessing. We can use that A, B, C, D, E, F mnemonic there. So we want to make sure we are assessing using a pain scale and being consistent with that scale that's being used. We want to believe what is reported. So if they tell you they're having pain in their chest or their feet or their legs or whatever, we're going to believe what they are reporting. We're going to try to investigate complications or causes of that pain. We're going to treat with opioids or narcotics as scheduled medications. Once that pain is under control, we could switch to a PRN basis or maybe even less severe NSAIDs. We're going to help use coping mechanisms, help with distraction, keep that environment quiet, dark, private, and then make sure we're hydrating with lots and lots of fluids. So when we think about sickle cell crisis, let me cover this next one here. This is the sickle cell crisis. It's cell clumping can occur. So vaso-occlusive crisis causing significant pain and organs damages can be our biggest concern. Signs and symptoms include fever, tissue or engorgement, swelling of the joints, and again, they're going to have lots and lots of pain. Abdominal and long bone are our main source of pain. They can have a hand-foot syndrome and definitely some joint pain. When we're thinking about complications, infection, stroke, URIs, just that infectious process, any leg ulcers, splenomegaly are complications for it. So how are we going to treat them? You can think of that mnemonic: HOP, hydration, oxygen, and pain relief. They're probably going to get on some type of antibiotic therapy as well. So as a recap, if we're in sickle cell crisis, we're going to increase the fluid intake, double that maintenance requirement, and making sure we're getting some oxygen on board. We do need to educate our families. Any febrile illness, they need to seek attention right away. Make sure they're getting their vaccines on time and scheduled, they're staying hydrated, they're avoiding those high stress situations. If they're having more pain, they've got to go see that provider immediately to try to get some of these things done before crisis occurs. Any signs of infection or signs of stroke need to get help quickly. Infectious signs might include fever, pale, listless, abdominal pain, swollen joints, and then our stroke symptoms would be headache, numbness, or visual changes. So just educating those families to monitor for those signs and symptoms. The medication of choice for our sickle cell patients is hydroxyurea. It increases the level of fetal hemoglobin. Red blood cells live longer and sickle less. It can cause reversible neutropenia, but the biggest problem is compliance with our patients. This is a medication they're going to have to take every single day, sometimes a couple of times a day, depending on the age of the patient. The next one we're going to talk about are clotting disorders. So we know that clotting occurs after an injury. The blood clotting system relies on certain factors in the blood and platelets to perform this adequately. Major bleeding disorders can affect children, including idiopathic thrombocytopenia purpura. This is immune response after a viral illness that produces antiplatelet antibodies. Henoch-Schönlein purpura, HSP is what you've maybe heard, develops after a viral or bacterial infection. Disseminated intravascular coagulation, or DIC, is a critically ill patient that have overactive coagulation. And then factor deficiencies is what we're going to really focus on and look at. We're going to look at that hemophilia, factor 8 deficiency. You can also see von Willebrand's, hemophilia B, otherwise known as Christmas disease, or factor 9 deficiency, and then hemophilia C, which is that factor 11 deficiency. So if we're looking at idiopathic thrombocytopenia purpura, remember this is the one where the immune response after a viral illness that produces antiplatelet antibodies. So petechia and purpura are the two things that I want to look at. The antiplatelet antibodies lead to the development of this petechiae or purpura and excessive bruising. So petechiae are those pinpoint hemorrhages that occur in the body that do not blanch to pressure. Purpura are those larger purplish areas of hemorrhage in which blood collects underneath the tissue. Recovery is typically spontaneous. Complications can be severe hemorrhaging or bleeding into vital organs or intracranial hemorrhage. That's typically very rare. Treatment of this is going to include corticosteroids or IVIG. So when we think about hemophilia, historically, this is a prognosis that a lot of kids that got this, they died before the age of 5. Now, mild to moderate hemophilia patients can live very normal lives. It's a group of hereditary bleeding disorders, of deficiencies of specific clotting factors, and it is usually an X-linked recessive trait. So there are two types of hemophilia. Hemophilia A is our classic hemophilia. It's the most common type and accounts for about 80% of all the cases. Again, it's an X-linked recessive trait. About 1 in 5,000 males are affected. Females are typically carriers. Factor VIII deficiency. The degree of bleeding depends on the amount of the clotting factor. And then hemophilia B, or Christmas disease, is a factor IX deficiency, and it accounts for about 15% of hemophilia cases. So what does hemophilia look like? Classic or clinical manifestations can range from mild to moderate or severe. They have hemoarthrosis, which is the most common seen symptom, and that's that bleeding into the joint spaces. There can be extensive bleeding that may be seen after minor surgical procedures, such as like a circumcision, maybe a tooth extraction, just that excessive bleeding. So why may symptoms not be seen after about 6 months of age? So let's say they have hemophilia. We don't know it though until at least after 6 months of age. And what's the reason for that? Well, they become more mobile, right? They're starting to roll, they're starting to crawl, they're starting to stand and walk, and that's just going to lead to more injuries, more bumps, more bruises, more falling. And then this is when we can really see those hemophilia signs. So with hemophilia, there is a deficiency in one of the coagulation factors in the blood. Factor VIII is for hemophilia A, and we can give factor VIII and they live a very normal, healthy life. This can be done in the home setting. We do need to remember that hemophilia is not hemorrhage. It's bleeding at a normal rate. It just continues to bleed, which can lower that hemoglobin because the bleeding occurs for a much longer period of time. So when we identify that bleeding, we need to hold pressure and we need to give that factor VIII. Some of the interventions for hemophilia is close supervision, a safe environment. With dental procedures, we just need to be in a very controlled situation, and the dentists need to just be aware that they have this disorder. We only want to shave with an electric razor. If we shaved with a regular razor and we nicked it, again, it's going to be causing excessive bleeding. So they only get electric razors. Superficial bleeding, we want to apply pressure for at least 15 minutes plus ice to help vasoconstrict. If they have significant bleeding that occurs, they may need a transfusion for that factor replacement. So let's move a little bit into childhood cancers. We do know that childhood cancers differ from adult cancers. Embryonic tissue that mutate rapidly. So childhood cancers grow in the connective tissues that are formed during the embryonic growth, while adult cancers form in the skin or tissue cells that line the internal organisms. So it's really that embryonic versus epithelial. Adult cancers can also be influenced by environmental factors. Childhood cancers are not environmentally related. So how do we treat childhood cancers? We do chemotherapy and radiation. Occasionally stem cell transplantation is also needed. Chemo works to destroy the cancer cells. Unfortunately, these medications also disrupt normal cells, causing adverse effects that may include immunosuppression, increased incidence of infection, nausea, vomiting. Radiation is used to kill those cancer cells. Hematopoietic stem cell transplant, also known as bone marrow transplant, uses high doses of chemo and radiation to the point of destroying the child's blood marrow. So we use it in very advanced cancers. So common types of childhood cancers, leukemias, ALL is more common than the AML. Lymphomas, you have your Hodgkins and your non-Hodgkins. Brain and spinal cord tumors are listed there. And then some other types of tumors that may be familiar for you are your osteosarcomas, Ewing sarcoma, retinoblastoma, Wilms tumor, and rhabdomyosarcoma. So So let's talk a little bit about leukemia. It is the most common form of childhood cancer. About a third of all childhood cancers from ages 2 to 10. Acute leukemias are rapid, progressive disease affecting the immature cells. Chronic leukemias progress more slowly, permitting maturation of cells so that they retain some normal function. 85% of ALL cases occur in those kiddos between 2 and 10 years of age. Prognosis is based on that WBC count. Leukemia is an unrestricted proliferation of those immature white blood cells in the blood-forming tissues of the body. The liver and the spleen are the most severely affected organs when we talk about leukemia and we talk about acute lymphoblastic leukemia. Fatigue, weight loss, growth arrest, muscle wasting are all going to be very classic symptoms. So we're looking at those nutritional needs of these patients. As far as therapeutic management, we're going to focus on giving chemo to eradicate some of those cells. We also may do a bone marrow transplant. As far as nursing assessment, common signs and symptoms are going to be fever, recurrent infections because of those immature white blood cells, usually bleeding or bruising because of the decreased platelet count, bone pain, vomiting, anorexia, unsteady gait. We're probably going to see pallor because of that decreased RBC. Again, that bone pain, they're pushing the cells out of that bone marrow as quickly as possible, which is just putting pressure on that bone. As nurses, we need to make sure we are empowering our patient and our families with the knowledge of the disease and treatment so they can have a more positive outlook and improved quality of life. Symptoms of leukemia are listed here. If you can remember the mnemonic ANT, anemia because of that decreased hemoglobin, neutropenia, which puts them at risk for infection, and thrombocytopenia, which puts them at risk for bleeding. Remembering that numerous immature white blood cells act like ants in an ant colony. So let's look at our lymphomas. Hodgkin's disease is more prevalent in those in the ages of 15 to 19 years of age. Non-Hodgkins is usually more prevalent in children less than 14. Hodgkin's disease is a neoplastic disease that originates in the lymphoid system. It can metastasize to the liver, the spleen, and the bone marrow. There's usually staging that occurs, staging 1 through 4, also classified as A or asymptomatic, or B, the presence of symptoms. Signs and symptoms include weight loss, fever, night sweats, fatigue. When you palpate an enlarged lymph node that may feel rubbery and clustered, that is a very classic symptom of Hodgkin's disease. Non-Hodgkin's is about 60% of our pediatric lymphomas. Types of tumor and location of tumor in the brain determines the extent to which it can be safely resected. Patients with hydrocephalus from the tumor or the removal of the tumor may require a VP shunt. We talked about those a couple of weeks ago. Radiation will be used, but only given to children older than 2 because of those long-term neurocognitive effects. Remember, radiation damages those tissues. We're going to do lots of neuro checks. We're checking for strabismus or nystagmus, those sunset eyes, remembering that's that increased cranial pressure, altered coordination of gait, or altered sensation. Mannitol will be given to decrease cerebral edema. We're going to frequently check vital signs, pupillary checks, as well as level of consciousness. We're going to monitor for those signs of increased cranial pressure. They may become combative or aggressive as they gain consciousness after surgery, so we may have to restrain those patients just because of safety. So restraints upon awakening might have to happen because of the combativeness or the aggressiveness that is happening. Bone and soft tissue tumors are less common than some of the other cancers. Common sites are those long bones for your osteosarcoma. Surgical removal is necessary. Chemotherapy may be administered after the surgery. Radical amputation versus limb salvage procedure. Amputation of the entire extremity or the entire affected bone would be that radical amputation. If we're thinking about limb salvage procedure, we're just removing the affected portion of the bone and replacing it with a cadaver bone. Remember, if this is a teenager, their biggest concern is that body image, self-esteem. They may complain of dull bone pain, bones that don't produce those cells very quickly, so it's very slow. You may see a limp, you may see a gait issue. So if you start seeing those things, we need to be concerned. As far as health history related to the hematologic function, these are just those things, again, that we're going to talk about. What was their birth or maternal history? Were they given that vitamin K after birth? Do they have recent illnesses related to blood cell distribution? What's their sleep-wake pattern? What's their bowel elimination pattern? Family history, typical diet, risk for lead exposure. That's going to encompass all of these different things that we have talked about. Some of the common labs and diagnostics that we might see, we're going to do blood type and cross-match. Just going to prepare that patient that they may need that transfusion based on blood loss from trauma. Clotting studies are those clotting factors and platelets, so our PT or PTT levels. Coag factor concentration helps diagnose hemophilia or DIC. Our CBC and differential will tell us about the breakdown of the WBC count. That might be helpful in helping us determine what is really going on. Hemoglobin electrophoresis evaluates the normal versus abnormal hemoglobin, so that's our sickle cell patients. Iron evaluates iron metabolism, so our anemics. Lead measures our lead level in the body. It's helpful for us to know if that's a lead poisoning happening. Our reticulocyte count measures the immature RBCs. High levels could indicate bleeding or anemia issues. And then our serum ferritin measures the ferritin, which is that major iron protein in the blood. It's the most sensitive test for our iron deficiency anemias. These are our main components of a CBC. RBC was the actual number of the counted red blood cells. Hemoglobin and hematocrit may vary based on how much blood is in our patient's system. RBC's indices measures the cell diameter. The WC count with the differential can break down the cells by neutrophils, eosinophils, basophils, so you can see if there's a shift to the left, which may be occurring, which just means there's a worsening infection happening. Platelet count is the number of platelets, and then our MPV is the measurement and size of those platelets. So here is our hemogram, and this is in your book. Just make sure you know the normal or the breakdown of the normal hemogram values. You can see WBCs, RBCs, hemoglobin, and hematocrit and platelets. They're all important here. Platelets don't really vary much with age, so you will be looking at these labs very frequently and consistently. So I would just make sure you're familiar with them. Children that are diagnosed with hematologic issues, anemia, bleeding disorders, and cancers are going to have very similar symptoms. Their skin colors are going to change. They're going to be pale. They may have bruising. They may be flushed. And that's really the first sign of a problem. As far as mental status changes, they're going to be tired, lethargic. They're going to have decreased hemoglobin, which causes a decrease in that oxygen delivery to the brain, which means their mental status is going to change. A thorough assessment approach, meaning that we're inspecting, we're observing that overall appearance and energy level of that child. And we're going to document all of those findings from head to toe We're going to auscultate breath sounds, heart sounds, bowel sounds. We're going to percuss the abdomen, noting any presence of any dullness and palpating that liver. So making sure we're assessing for hypoxia, fatigue, pallor in children with the anemia as well. So after that very thorough assessment, here are our priorities: fatigue, pain, impaired physical mobility, ineffective health maintenance, anxiety, and ineffective family coping would be definitely high priority for this patient population. Some of the common medical treatments, nursing care that we can think about are supplemental oxygen. Remember, hypoxia is huge with all of these, especially if our sickle cell crisis patients are coming in, or severe anemia. So we want to put some oxygen on them. Blood product transfusions will be seen with those RBCs, white blood cell, and platelet disorders. Splenectomy. Remember, our spleen filters out that bad blood cell and becomes enlarged. It may need to be removed. As far as hemopoietic stem cell transplant, this is an option for treating those hematologic disorders as well as some of our cancers. We have IV hydration, a lumbar puncture. We can obtain some CSF, or that cerebral spinal fluid, to determine if any metastasis has occurred to the brain or the spine. Radiation treatment we can do for solid tumors, leukemias, lymphoma. Chemo and radiation is used as that first line, and then hemopoietic stem cell transplant. Other treatments, chemotherapy is that first line of treatment, but remember, it can't differentiate between cancer cells and healthy cells, so unfortunately we do see some healthy cell issues. Anything that replicates quickly will affect the chemo. Bone marrow transplant from another person or self. We'll do cycle damaged cells out and purge abnormal cells, leaving them with no immune system. So essentially, we just pump them with chemo until they have no immune system, and then hopefully we can do that bone marrow transplant where those new stem cells don't have anything to replicate, no bad cells to replicate. Here are your common medications that you may see: iron supplements, folic acid for our iron deficiency kids. Defracirox is our iron toxic chronically infused children. So if they've gotten several blood transfusions, they have really high iron, you might see this medication being given. Factor replacement replaces those clotting factors for hemophilia. Antibiotics help kill bacteria. Hydroxyurea stimulates that hemoglobin F in sickle cell anemias. IVIG is for our idiopathic thrombocytopenia. We'll see chemo and we'll see biotherapy. Lots and lots of support for these families and these patients. There's going to be a huge psychosocial impact on this patient population. So just giving this family lots and lots of support as nurses, and support in the community with other resources. And that concludes chapter 46. If you have any questions, you can shoot me an email or we will chat about it